Okay. Thyroid disease is the second only to a diabetes mellitus as the most common endocrinopathy that occurs in women during their reproductive years. Symptoms of thyroid disease often mimic common symptoms of pregnancy, making it challenging to identify. Poorly controlled thyroid disease is associated with adverse outcomes during pregnancy, and the treatment is an essential part of prenatal care to ensure maternal and fetal well-being. And it affects between 1 to 2% of pregnant women. The hypothyroidism is present in 0.5%, hypothyroidism in 0.5 to 0.2%, and mostly it's the Graves' disease accounts the 90% of this pathology, and the so-called postpartum thyroiditis, which accounts 5 to 10%. To understand abnormal thyroid function in pregnancy, a review of normal physiologic change is warranted. Because of the estrogen-mediated increase in thyroid-binding globulin, the increased volume of distribution of thyroid hormone and the placental metabolism and transfer of maternal thyroxine, there is a 20 to 40% of increase in the thyroid hormone requirement as early as the 4th week of gestation. There is 20% increase in thyroid gland size due to hyperplasia and increased vascularity. The increase in estrogen increases the thyroid-binding globulin and decreases free thyroxine levels. The rise of human chorionic gonadotropin level, the structural similarity with thyroid stimulating hormone, increase in T4-T3 ratio and decrease in TSH. Decline in availability of iodate, which is related to increased renal clearance and overall losses to the fetus and the placenta. Thyroxine requirements in pregnancy happens due to increased level of thyroid-binding globulin, which leads to decrease in free thyroid hormones, and it leads to stimulation of hypothalamus pituitary thyroid axis stimulation. The increase in human chorionic gonadotropin stimulates thyroid stimulating hormone receptors, and increase in peripheral metabolism of T4 thyroxine to T3 thyroid. The normal values in pregnancy, they differ from non-pregnant values. Look, the TSH level is considered normal up to 2.5 during first trimester and up to 3.7, 3.5 up to third trimester. When screening should be done? If there is current thyroid therapy, so the screening is not universal. Only in cases of current thyroid therapy, if there is family history of autoimmune thyroid disease, goiter, or history of autoimmune disorder, high-dose neck radiation, postpartum thyroid dysfunction, previous delivery of infant with thyroid disease, therapy for hyperthyroidism, and in cases of type 1 diabetes mellitus. Okay, now let's start with the hyperthyroidism. when the level of thyroid hormones are excessive. The incidence is about 0.5 to 0.5%. Types are subclinical, overt, and gestational. What means subclinical hyperthyroidism? When there is suppressed level of TSH, but the normal levels of free fractions of T4 and T3. Overt hyperthyroidism means suppressed levels of thyroid stimulating hormone, at the same time elevated levels of free fractions of T4 and T3. And the last one, gestational hyperthyroidism, which is detected in pregnancy. What are the causes of thyrotoxicosis in pregnancy? On the first place, most common in 90% of all cases, there is Graves' disease. The next one is toxic nodule. It might be single or multiple. Subacute or silent thyroiditis. Excessive exogenous thyroid hormones. And so-called gestational thyrotoxicosis, which is related to hyperemesis gravidarum, gestational trophoblastic disease, hydatid-4 mole, it's one of the types of gestational trophoblastic disease, by the way, multiple gestations, hydrops, and rare types, TSH-producing pituitary tumor, iodine-induced, or struma ovary. Gestational tensile thyrotoxicosis, they do not need any treatment. The cause is cross-reactivity between human chorionic gonadotropin and TSH at thyroid receptor, because you know that the alpha chain of the HCG and TSH, they are similar. And nausea and vomiting leading to dehydration, electrolyte imbalance, and weight loss. The spontaneous resolutions happens by the 18th week, and no antithyroid medication should be done. As we mentioned before, that the most common cause is Graves' disease, which is autoimmune disorder with incidence of 0.5%. Most common cause of hyperthyroidism. Physiology. Antibodies stimulate thyroid receptors and thyroid hypertrophy and hyperfunction. What type of antibodies do we mean? There are 4 types of antibodies: thyroxine peroxidase, thyroglobulin, microsomal, and thyroid receptor antibodies. The TSH receptor antibodies are presented in 2 types of immunoglobulins of G subclass. 2 types, stimulating and blocking. Stimulating, they thyroid stimulating immunoglobulins, they cause Graves' disease. Blocking, thyrotropin binding inhibitory immunoglobulins, they cause Hashimoto thyroiditis. Immunoglobulins, they cross the placenta barrier, and as a result, they affect fetal thyroid function. The first class immunoglobulins, which cause Graves' disease, they lead to fetal tachycardia, goiter, intrauterine growth restriction, craniosynostosis, premature skeletal maturation, and hydrops. The second types, which cause the Hashimoto disease, they lead to fetal bradycardia, goiter, and intrauterine growth retardation. What are symptoms and signs of hyperthyroidism? There is nervousness, agitation, fatigue, tachycardia and palpitation, heat intolerance, increased appetite at the same time. Despite on this increased appetite, weight loss, change in bowel habits, more frequent stools, skin, hair and nail change. Skin is soft and moist, hair is soft, fine and thin. Eye size distinct from Graves' ophthalmopathy, we will talk about that. Lid lag, lid retraction and proptosis. On the picture on left you can see lid lag sign, and the right picture you can see lid retraction side. There are specific signs which are characteristic for Graves' disease. The Graves' orbitopathy, chemosis, which means swelling of conjunctiva, proptosis, exophthalmos or bulging orbit, disconjugate gaze, when there is double vision on looking to the extremes of the visual field, pretibial myxedema, so-called thyroid dermopathy, bilateral, firm, non-peeling, asymmetric plaques or nodules, more often confined to the pretibial area. But at the same time, you should know that they may occur anywhere. Thyroid fluid and clotting. I will show you pictures now. Okay. This is signs of Graves' disease. Eye signs, you can see here. Ophthalmoplegia, lid lag and lid retraction. Pretibial myxedema, you can see it here and here, and thyroid acropathy. How hyperthyroidism affects pregnancy and fetus. Considering the pregnancy, spontaneous abortions, preterm births, preeclampsia and associated with that placental abruption and intrauterine growth restriction, perinatal morbidity and mortality, congestive heart failure and thyroid storm. How it affects the fetal. The congenital malformations of heart, kidney or brain are common. Fetal Graves' disease in infant, fetal tachycardia, cranial synostosis, low birth weight, fetal goiter, and eventually fetal demise. How to treat this condition? Mostly thionamides are used. On the first place, propylthiouracil, PTU. It inhibits conversion of thyroxine to triiodothyronine. It crosses placenta less readily. A dose of 300 to 450 milligram is divided to 3 doses. It belongs to category D medications. What are the side effects? Iatrogenic fetal hypothyroidism, transient leukopenia, agranulocytosis, hepatotoxicity, vasculitis. Improvement in condition is seen in 3-4 weeks, but it should be tapered as pregnancy progresses. The next is methimazole. Dose is between 5 to 20 milligram. It crosses placenta more readily. Again, it belongs to category D because it can cause the methimazole embryopathy, esophageal atresia, choanal atresia, cutis aplasia, and the side effects are transient leukopenia, agranulocytosis, hepatotoxicity, and vasculitis. The dose should be monitored every 3-4 weeks with the checking of the levels of free thyroxine. Improvement is seen in 3-4 weeks and full response is achieved at 8 weeks. Again, it should be tapered as pregnancy progresses. The next pathology is hypothyroidism. It is 0.3 to 0.5% for overt hypothyroidism and 2 to 3% for subclinical hypothyroidism. Again, there are several types. Primary. What means primary? When there is inadequate thyroid hormone production despite pituitary gland stimulation, including iodine deficiency. So, the pituitary stimulates, but the thyroid gland does not respond to this stimulation. Next type is central. When there is insufficient stimulation of the thyroid by the pituitary or hypothalamus. Next type is subclinical hypothyroidism, when the asymptomatic individuals show elevated levels of TSH but normal levels of thyroxine. And the next type is overt hypothyroidism, when the thyroid hormone is deficient and TSH levels are elevated. Again, what are the causes of the hypothyroidism? If we talk about the primary hypothyroidism, when there is normal stimulation but not response from the thyroid gland, Hashimoto thyroiditis, subacute thyroiditis, endemic iodine deficiency, suppurative thyroiditis, previous thyroidectomy, previous radioablation, and medication exposure. When we talk about secondary hypothyroidism, there is hypothalamic or pituitary tumor, surgery, radiation, Sheehan syndrome, lymphocytic hypophysitis. Remember, we talked about Sheehan syndrome when we talked about the obstetric hemorrhage. The next is subclinical hypothyroidism and eventually isolated hypothyroxinemia. Let's talk about the Hashimoto thyroiditis, which is lymphadenoid thyroiditis. It's chronic lymphocytic inflammation. It's most common cause in iodine sufficient population, so it's not related to iodine deficiency. The incidence is 4 to 1,000 cases. Females account ratio female and male is 5 to 1, and the cause is that the anti-thyroid antibodies damage the gland, and the transient hypothyroidism eventually leads to hypothyroidism when 90% of gland is destroyed. The symptoms and signs of hypothyroidism include fatigue, constipation, cold intolerance, weight gain, carpal tunnel syndrome, hair loss, voice changes, reduced memory, slower thinking, muscle cramps, dry skin, goiter, insomnia, periorbital edema, myxedema, and prolonged relaxation of deep tender reflexes. How the hypothyroidism affects pregnancy and fetus. What might happen in pregnancy? Early pregnancy failure, spontaneous miscarriages, preterm delivery, preeclampsia, placental abruption, malpresentations, low birth weight, stillbirth, and postpartum hemorrhage. How it affects fetus? Neurodevelopmental delay. That's why so important to find the cases of hypothyroidism in pregnancy. Deafness, stunted growth, peripartum hypoxia, increased risk of neonatal mortality. The management of hypothyroxine, there is gold standard, levothyroxine. It's most widely prescribed treatment which belongs to category A, which means that it's safe for mother and fetus. There are a lot of available dosages starting from 25 up to 300 micrograms. How to calculate the dose? Look, if we know that she is hypothyroid before the pregnancy, the 30% increase of the dosage should be from non-pregnant values. If it's newly diagnosed in pregnancy, then 1 to 2 microgram per kilogram daily, or approximately 100-150 microgram of levothyroxine daily. The TSH should be checked every 4-6 weeks following dose change, with the TSH goal between 0.5 up to 2.5 micro IU per liter. The TSH should not exceed 2.5. Once stable, TSH can be checked every 8 weeks, so every 2 months. The levothyroxine, of course, has its adverse effects on mother. These effects are related to over-treatment, and if so, the signs of hyperthyroidism might be present: transient hair loss and decrease in body mass weight. On fetus, there is smaller head circumference and low body weight. The cases of neonatal hypothyroidism include the thyroid dysgenesis, thyroid aplasia, thyroid hypoplasia, and thyroid ectopy. In some cases, it might be drug-induced or mutations of TSH receptor and resistance to thyroid hormone. How to manage fetal hypothyroidism? If it's diagnosed antenatally, we should know that fetus easily absorbs thyroxine from amniotic fluid, and in third trimester requirement is 6 microgram per kilogram daily. Intraamniotic administration of 250 to 500 microgram of thyroxine at 7 to 10 days interval. In term infants, the requirement is higher, 10-15 micrograms per kilogram daily, and TSH levels should be kept below 5 micro IU, and T4 levels should be kept at 10-16 microgram per deciliter. What should include management after delivery in postnatal period? Care of neonate, breastfeeding, and watch for signs and symptoms of maternal worsening. And we mentioned postpartum thyroiditis. Postpartum thyroiditis is an inflammation of thyroid that occurs in women after the delivery, and it occurs in approximately 5-10% of women who are at risk of developing of postpartum thyroiditis. Any woman who has autoimmune disorders, who are positive for anti-thyroid antibodies, who has history of previous thyroid dysfunction, who has history of previous postpartum thyroiditis, and family history of thyroid dysfunction. How to manage this condition? The treatment depends on the pace of thyroiditis and degree of symptoms, because the thyroiditis may be in type of hyperthyroidism and hypothyroidism. Women presenting with thyrotoxicosis may be treated with beta blockers to decrease palpitations and tremors. Anti-thyroid medications are not used because there is not overactive thyroid. The hypothyroid phase is often treated with the thyroid hormone replacement with levothyroxine. If the hypothyroidism is mild, so no therapy is needed. If thyroid hormone therapy is begun, treatment should be continued for approximately 6 to 12 months and then tapered. Thank you for your attention.